Okay, so thank you for taking the time to watch this, wherever you are. As you can see, my name's Chris White, and I've popped a picture up there just so you can put a name to a face. I'm going to talk about my PhD research, which is looking at the links between active travel and public health, and how public health teams perceive active travel and how they work on active travel. So it's a continuation of my presentation for the conference last year. Most of my work has been based in Greater Manchester, looking at the public health workforce over there, and so I'll come on to explain exactly why. Before that, what drew me towards public health was the 2012 Health and Social Care Act, which meant that public health teams, which were previously with primary care trusts, moved into local authorities. And that studied quite a lot of active travel lobbyists and those interested in this area, especially because, as outlined by Insel here, it might be possible to develop joint investment approaches between transport and public health. And it just meant that public health could potentially lean on other departments to consider how their work impacted public health outcomes. Alongside that, Greater Manchester signed off a health devolution deal, where they are now in charge of a £6 billion annual health budget. Alongside that is a consolidated transport budget, and of course the 60+ million Cycle City funding that they received from the DfT. So a lot of policy movements here that potentially would give rise to a increase in active travel work. Especially when you look at that devolution deal and the lead policy of that taking charge. And to quote one of my participants here, there are 4 priorities, but the 2 key ones are a radical upgrade in prevention and a transformed neighbourhood offer. So prevention is a really important part of that devolution plan, and as you go into the policies, active travel is mentioned as one potential intervention that could form a key part of the prevention offer in Greater Manchester. In terms of my methods then, there were 42 interview participants recruited from these various groups on that second bullet point. That was largely informed by the NICE guidelines on how local leaders could look to improve active travel. They highlighted these different roles as playing an important part in that. So I contacted the sample based on policy documents, meeting minutes, corporate websites. There was also a snowball sample, whereby at the end of the interview I asked if anyone else should be taking part. All transcribed verbatim and analysed thematically. I'm coming at this from a sociological perspective. This presentation isn't too sociology heavy, but if anyone wants to discuss this work further, I can definitely get into the meat of that. Okay, so on to the findings then. Every policy you read, and this follows on really well from that quote from one of my participants, the health and social care reforms of Greater Manchester were all about prevention. And a lot of this was influenced by money. There was a predicted shortfall of 2 billion within 7 years if Greater Manchester continued in the same manner, and that manner was largely continuing to fund shortfalls in hospital beds and other forms of treatment work. So there's a recognition that they had to do something different. They were forced to do something different. And leaders were really emotive about the potential for this. We've just got a golden opportunity to recognise that population health and supporting residents to do well is connected to economic growth. Some participants thought brilliant, whatever the motivator, we're happy to go with it. Others questioned if leaders and if their heart was really in this, if from a money perspective it was something they had to do, but really when it came down to it, their bias was very much towards treatment services. I'll come on to talk about that a little bit later. In terms of where active travel fitted into this then, all participants suggested that active travel is something that public health teams should be looking at. However, for many, it was just one of a range of physical activity options for those looking to increase their activity. And it was only those who were more closely involved and closely tied to the promotion of active travel who suggested that it has a particular potential to make an impact amongst inactive populations. Well, I have to say that did sway between participants, and it did come down to their interest and their attachments to active travel, because those who weren't as closely involved suggested that cycling might be something that isn't the ideal option for completely inactive people, because there's quite a low starting point there, and quite a lot of barriers there, I guess. So that prevented many people for looking at it. But those closely involved, they just said, well, it's a great way to incorporate exercise into your routine. The evidence bears out on this. What better way of getting to school or work on your own steam? And participants were particularly interested in the daily routine and convenience aspect of this. For them, the compelling reason wasn't health. In terms of people's interest, it wasn't. They didn't do it for the health, but they did it for cost and convenience. You've delivered the health without getting them to change their lifestyle in other ways. So you've been able to build physical activity into people's working days and make it a routine. So looking at how things were developing then, how was this prevention agenda developing in Greater Manchester? Well, a common narrative was that the core agenda of the GM Health leaders had been dominated by hospital care, looking at how they can make that more efficient. In the early stages of devolution. The evidence suggests that when an intervention goes in, so prevention, it's going to be much more effective than anything we can do to change how we deliver health. But we tend to put all our efforts and time and money into reorganising healthcare rather than improving interventions to affect health. However, it suggests that these various restructures of hospital care limited the intentions of public health teams, and many of their proposals were perhaps overshadowed by the clinically focused activity of the NHS. I guess we get distracted by hospital services and the wrong end of healthcare spectrum. It is inevitable you have to spend a lot on interventions through hospital services, but usually there is nothing left over. It has all been spent and little is left over. Of course, participants recognised that you need substantial spends on hospital care, but they were perhaps dissatisfied in the way in which funding was disseminated, in that there had been a hierarchical model developed whereby hospital care was funded, and public health teams would be working on whatever funds was left over. There were also concerns about what was actually spent on public health was still ostensibly treatment services, so smoking cessation programs, sexual health, alcohol, etc. And for many participants, all this really equaled clinical prestige, or a medicalisation process, where clinical work was heavily prioritised. And this wasn't just for funding issues, but also perceptions of public health teams. A lot of public health officers suggesting that their comments weren't afforded the same kind of weight as those of clinicians. Some even remarking that when they moved into public health, people would approach them with the attitude of, oh, where did it all go wrong? So where does this leave active travel then from a public health perspective? As suggested by one participant here, I think it's quite high priority within the public health workforce, but I think the wider health workforce, no, it is not up there. It doesn't have the same profile as, smoking or alcohol. And that was reflected in what was delivered, as suggested in the previous slide. It has managed to get itself active travel in the nice to do and not the must do. And that is common with a lot of other prevention measures at the moment. Austerity has meant that there is enormous pressure on everyone's grants and budgets. It's easy to cut things that don't have an obvious direct impact on particular individuals straight away. So it must be said that whilst we've got this picture of prioritising treatment services, public health teams moved into local authorities more or less at the exact same time as huge austerity cuts. And so, of course, public health budgets have been severely cut. And so the funding that is left with public health has to be spent on these treatment services. And so there's very little money left over for prevention. However, some participants suggested, yes, that is the case, but true public health actually sits with other areas like transport, like education. To look at this quote, if we're looking at what does investment in public health look like, then you have to look at some of the mainstream investments from Transport for Greater Manchester or housing stock. That is public health, but it's not in anyone's budget lines as public health. And that was from a leader of the region. However, interviews with Greater Manchester transport bodies demonstrated a very similar picture. Again, there's a hierarchical model where instead of treatment services, it's big highways that are prioritised. ACTS travel funding is actually never permanent for transport for Greater Manchester. The roles there are never permanent. They're dependent on grant funding. And so there's very little continuity there as well. So in terms of recommendations then, well, it seems as though there's quite a need to look at how this cohesive network can be developed. How can there be permanent and consolidated links between public health and transport teams and housing teams, especially when we know that it's okay to say, well, true public health fits with transport teams, but actually they're still very much guided towards the car. They need that kind of public health influence, perhaps. And can leaders therefore be held accountable for their promises regarding intervention prevention? How can we develop greater understanding of legislation funding mechanisms? All Transport Greater Manchester work is based on grant funding. However, it seems from the sample that public health officers weren't perhaps too understanding of that. When you said, where should the responsibility lie? Well, they said, well, it's a TFGM thing. So it seems that ACTS travel really is a complex problem that needs to be owned. Responsibilities need to be marked out, and accountability needs to be developed, perhaps. We've been fortunate enough to discuss some of this work and our previous papers with a couple of government departments. So what have we been saying to them? Well, many local authorities have been able to effectively control their town planning, and in doing so have largely ignored the advice in policy documents. It's fair to say that up until now, ACTS travel policy has been very much advisory. And those who don't wish to go along with that have been able to effectively control what they're doing, regardless of the involvement of public health or not. The question I'll leave on is that we've seen now that we're due to see Active Travel England introduced, which is looks like it's largely going to be an infrastructure inspectorate, and I question whether, along those lines, is this gap between cities that have great infrastructure, actual infrastructure, or developing actual infrastructure, and those who don't, only going to widen, especially when local authorities know that high standards are now at stake? They're going to need to put a lot of time, money into these programs. Those who are willing, that might be great. Those less so, what pressure is there on those kind of places to push forward with their plans? Okay, that's me. My email's there if anyone wants to follow this up further. Thanks very much.